Okay, welcome everyone. We will start our kickoff webinar. It's the kickoff webinar of the fourth day of the European Public Health Week. We're very excited to be with you here on the topic Health Through the Life course, breaking down silos. It's getting more and more clear that if we want to really improve the health of everyone on this planet, we need to join hands and brains in a collective effort. And in our view, the population is not the problem, it's part of the solution to the health challenges. And this is why health, education, and learning are at the core of what makes health for all possible. Lifelong learning both is a personal asset for health and a societal health resource. And how can we do that? How can we encourage innovative solutions and sustainable solutions for our health systems? How can politics drive equality in care, access, and health prevention that leaves no one behind? And how can we channel what we call a continuum lifespan approach? Hopefully, we're going to find some of these answers here and more in this webinar. So my name is Goof Buys. I'm moderator for this event and manager of the UNESCO Chair Global Health and Education, which is co-organizing this event with the EUPHA and 3 EUPHA sections. And first of all, it's good to know that this recording, that there's a recording made of this video. And if you have any questions, you can use the Q&A, which is at the bottom of your screen. And we'll hope to answer all your comments and questions during this event. And also we use an additional app, which is called EUPHW, which you can click on here. You can do that by the QR code, or you can also go to the EUPHW.com, enter the event code, which is EUPHW 160524, and you can also send this code to a 06 number. So there are many ways to join via EUPHW. And then also you can find the link in the chat. And while you do that, you can answer three very simple questions, which gives us an idea of who you are, what your background is. So where are you now? Where are you located now? What is your background? I am and you have an option to choose. And the third question is what your background is. So while you do this, I'm happy to introduce our speakers. And our first speaker is EUPHW Nagovia, who is director of the EUPHA. Very happy to have you with us, EUPHW. You're also head of Department of Social and Behavioral Medicine and senior research leader of the Pavel University in Slovakia. And very sorry to hear the tragic news that happened in your country yesterday. And you will introduce the European Public Health Week and today's theme. So the floor is yours.
Thank you very much, Goof, for the kind introduction. And yes, indeed, I would like to share with you my screen. So I hope it will work. And welcome, everybody. It's very nice to greet you on behalf of the European Public Health Association. Just one small correction, Goof, I'm the EUPHA president, not the director, but it's okay. And it's my great pleasure to introduce you the European Public Health Association. For those who don't know, the European Public Health Association, and for the EUPHA family, I would like to highlight or inform you that together with our executive director, Charlotte Marchandise, we are working on rebranding the European Public Health Association. And this is part of the rebranding. EUPHA is here for you. This is our new slogan. And with this, I would like to say that EUPHA is an umbrella organization for national public health associations and institutes in the European region. We currently list 82 members from 47 countries or 47 national associations out of the 53 countries of the European WHO European region are our members. And EUPHW is the go-to organization for independent and evidence-based public health information. We champion public health and equity, and we share tailored evidence with policymakers and citizens, contributing to informed decision-making through our long-term program, analysis, advocacy, and action. And the tools that we are using to reach our aim, including capacity building and knowledge building, is the European Journal of Public Health, which is a high impact factor journal, the EPH annual conference, the largest public health event in Europe, but also worldwide with regard to the diversity and richness of the program, the EUPHW newsletter, which is sent to 40,000 public health professionals, the 30 EUPHW-themed sections and working groups, including the co-organizers of today, even the section on healthy aging, health literacy, and health promotion. And we are also, of course, active on social media in European projects, participating in strategic meetings, and we have the rapid response team to react very quickly on requests from the politicians or policymakers or also journalists. And we, of course, in Europe are collaborating also with other non-state actors. And it's my great pleasure indeed to introduce you or to spend a couple of more information on the European Public Health Week. The aim of the European Public Health Week is to celebrate public health in Europe and also to connect those who contribute to better public health across the European region, promote collaboration among the public health community. And the idea for organizing this in Europe came actually from one of our members, the Austrian Public Health Association. And referring back to what you just said, Hoef, in the beginning, that, yeah, politics and public health are interlinked. And also this week's theme is health is a political choice. And we will see what will be the consequences for Slovakia. But in any case, as we've heard also during the high-level panel of on Monday, it's really the politics and public health are very much intertwined, and we have to collaborate with the politicians and policymakers. And finally, what I would like to highlight this morning is that the theme of today's kickoff webinar, Health Through the Life Course, Breaking Down the Silos, is something which is very close to the EUPHW philosophy and also to me personally. And this slide comes from my first ever presentation as being the EUPHW president in 2020 for the European Public Health Conference. And I really believe that the whole is greater than the part of the sums. The sum of the parts, sorry, as aptly formulated by Aristotle, and which is very nicely also illustrated by a Roman mosaic. So I'm very much looking forward to today's presentations from my colleagues, and I'm so pleased to have this European Public Health Week and this particular webinar co-organized, especially with UNESCO chair together. Thank you very much, and over to you, Hoef.
Thank you very much, Iveta, for your short and excellent introduction. And yeah, as you can see, it's we are part of a very big event, full, rich week. And without further ado, before we go to the next speaker, we have the information of you as audience, because we want to involve you as much as possible in this event. And so here, what we more or less expected, most of you are coming from Europe, but I also see from the European region and even Australia. So happy that, and if it would be bigger, we would have seen more diversity inside the European region. But from India also, oh, that's great. Dr. Alaka Chandak, we just connected on LinkedIn this morning, so welcome. So this is how it goes. This is how we are building community here right at this moment. Very happy to see this. And next slide is the background. So we have, as you can see, most of us here say that they are researchers. We have practitioners with us, policymakers, students, and other. That's the very intriguing one. And next slide is the background. Well, most of us have a background in health promotion, but also in healthcare, health literacy, in education, and other. And now I see we have somebody from Golda from Nigeria. So Africa is also here. Welcome. And without further ado, I would like now to give the floor to the speakers of this morning. And we are very happy to have four excellent speakers. And we've asked the speakers to be short, to be concise, and also that it provokes some responses from you here with us so they can reflect on it and we have a conversation. And first of all, it's my dear colleague and friend, Didier Jourdan, who is professor at the University of Clermont-Auvergne in France and shareholder of the UNESCO Chair in Global Health and Education. And he will talk about lifelong learning for health, breaking down silos, and talk about the UNESCO Yeonsu Declaration for Learning Cities and the new enactment guide based on that. So, Didier, the floor is yours.
Thank you very much, Rolf, and good morning to all of you, or good evening for the colleagues in the other side of the planet. Yes, I'm going to talk about the Yeonsu Declaration and the key issue of what we call lifelong learning for health, which is one of the key topic of our intersectoral work. 3 ideas to be shared with you. The first one, I'm going to be very brief because my good friend Rolf already gave a kind of introduction to my talk. The second one is to put the spotlights on the local level and especially the city level, and then to try to share with you some of the ideas we gathered from the experience of the more than 300 learning cities of UNESCO. As Rolf said, the population is not the problem in the field of health. It's more part of the solution. But of course, everybody knows that to move forward in terms of health for all, we need to build capacities. And building capacity goes through the development of the competencies and the knowledge of the population. And it's not only, few experts, few leaders, few policymakers. This is all the population, and this is also all over the life cycle. Very often we are focused on the young generation, the children, the adolescent, the young people when we talk about learning for health. But in fact, this is something that is one of the main characteristics of human being. We are learning from the beginning of our life to the end of our life. And Yonji going to talk about healthy aging in a few minutes, and it's probably going to put the emphasis on health literacy at old age. So clearly, when we talk about the future of public health, how could we push forward, the dynamic that would lead to health for all? We really need to have in mind that the development of the capacity of the population is critical. And to do that, of course, we need to break down silos. Where? How? Of course, at national level, the mission of the governments and the agencies is to create the conditions for real, effective intersectoral action. But the key level is probably the local level. Why? Because we have fantastic entities, institutions, people who are able to contribute to learning for health. Of course, this is the formal education setting, the schools, the higher education, but it's also the non-formal setting. And this is why Catherine, in a few minutes, is going to talk about the way in which we could harness the power of the non-formal education settings, what we also call popular education, to build the capacities of the population in the field of health. And this is the after-school program, the cultural system, also the healthcare system. We need to put the emphasis on the educational role of every healthcare professional, not only in the hospitals, but also the primary care system, the home health and care, because this is where we reach most of the vulnerable people of the population, elderly people, but also people with chronic condition and handicap. This is also the sports club, the faith communities. All of them are, I would say the galaxy of the non-formal education settings. and they are a key asset for public health. But of course, to build intersectoral work, to break down the silos, we need to speak the language of the people with whom we want to work. And the final, lever for change, this is the informal learning, families, peers, friends, social medias, and you all know that, for example, WhatsApp had a key role in the field of sexuality and relationship education, for example, during the COVID-19. And that's also true at the other end, I would say, of the life, where the social networks play a key role in information sharing. So what's important is to speak the language of the other people. And to do that, we need to have in mind that the focus for the people from the health sector and from the social sector, from the educational sector, is not the same. And that's why we always need to try to think through the point of view of the other people. And probably what we learn that is the most important from our experience with the more than 300 cities of the global network of learning cities is that for people to be involved in this process of lifelong learning, of course, we need to talk about the health literacy, the capacity for people to take care of themselves and their family. But we also need to open up to something bigger, which is citizenship, because, for an association working at a local level, what is absolutely major? This is the vision. This is where people want the young generation or the old generation to go to, and this is citizenship. And clearly, yes, to speak to the people, we need to have, I would say, a larger perspective. And of course, for us, this perspective, this is the Sustainable Development Goals, because things are linked. So lifelong learning for health is a key asset for intersectoral work and to break down silos at the condition that we put health in a broader perspective, meaning as a part of citizenship, and in our field, citizenship for health. This is the need for people to, have the knowledge, the skills, the capacities necessary for actively participating in decisions about health as citizens. What I just said is the background of an important declaration, the Yeonsu Declaration for Learning Cities. And 3 years ago, after a conference in Yeonsu, that's why the name is the Yeonsu Declaration, there were a work that led to more than 300 cities, and then all the executive power in these cities to declare that they really want to move forward in terms of lifelong learning for health and put, the emphasis on the development of policies and also the way in which it's possible to put these policies in practices. Now, having this framework, what could we do? I would say concretely on the operational level. Of course, as always, it's always complicated. Everybody's super busy. How could we create intersectoral work with people that are 100 under pressure from their side? And this is probably the key dimension of the work of the UNESCO Institute for Lifelong Learning and the UNESCO chair. The idea is not to implement a new approach of lifelong learning, but it's more to try to translate in every local context a dynamic that put together all the key actors of health, education, and social dynamics around a common project that is absolutely key for every policymaker at the local level. Have a look, we don't talk about implementing the declaration. We are talking about enacting, because enacting means that every process, of course, have to be translated at the local level. What is the only important slide of my talk? This is this one. What is the approach? The approach is, first of all, to realize that a lot of key actors at a local level also contribute to lifelong learning for health. Think of the boxing club in one of the cities with whom we are working. The educators, even if they are talking about box, of course, they are interested in contributing to health education to young people. And that's the case for all the sports clubs, for many associations. But of course, to move forward, we need to share that, to align it in a policy, and to improve it, of course, because there's gaps. Valuing, sharing, aligning, improving is one of the way how we could breaking down silos. And then how could we put together all that things around a unique flag? Again, it is by talking about the health learning pathway. Learning pathways now are really important at local levels because, you know, education is based on the contribution of many key actors at the local level. And having one of the dimension of these learning pathways focused on health is probably something that's gonna help in many, many cities to break the silos and build the capacity of the people all over the life, from the perinatal period to old age, by taking together all the dynamics, the families, the formal education settings, the workplace, the healthcare services, all the community services, associations, and sports clubs in a policy. But what's important is that this policy is mostly based on what is already done, and it has to be recognized and enriched. Then this is the idea, and the work done by the UNESCO Institute for Lifelong Learning is to try to put together all these initiatives. We are talking about knowledge production and transfer ecosystem. It means having the people, the practitioners, the policymakers, the academics together. But of course, nothing's possible without the people. Nothing about the people without the people. That's why participation is the key issue when you want to promote lifelong learning for health and to break down silos. Thank you very much. Over to you, Hof.
Thank you very much, DJ. It's great. And of course, I know what you were going to say. And maybe you could briefly give one concrete example. You know, with the speakers, we had a talk on Tuesday, which was really fun and exciting. And we asked every speaker to give a concrete example. So maybe DJ, from your own experience, a concrete example of this health learning pathway that you are involved.
Yes, we have many examples. I just would like to talk about the disadvantaged suburbs of a city within which the municipality organize, first of all, a collection of all the initiatives related to health based on meetings with the different associations, the different key actors. All that things together were integrated in the health learning pathway. And based on that, there were a capacity building process in order to improve the capacity of all these actors and settings to promote health. And that leads to a formal policy integrated in the policy of the cities.
And thank you, DJ. And there's a question from Charlotte, who's the director of the EUPHW. Very happy that you can join us, Charlotte. And you say that lobbies are very powerful in decision making. For example, when tractors came to Brussels, the EU Green Deal got jeopardized. So what are our tractors for public health, DJ?
This is one of the key issue, because it's a lot about lobbying and it's a lot about power. And I think our main tractors are people, because, you know, in all the pools, one thing you can observe is that the first key issue for people is health. And the campaign we have now for the European elections, I'm totally stuck by the fact that health is not present at all. And then probably our main tractor is the mobilization of the people, and especially, of course, the associations and the non-formal sector to contribute to influence the decisions at national and European levels.
Mm. And I think I was at the high level kickoff webinar on Monday, and I think there were a few tractors mentioned there, and maybe Iveta, you can say one that stood out from that event to share, and then we.
Well, I'm not sure so quickly to pick up. Perhaps you can share what you had in mind concretely.
No, but you were leading that event and I had to leave earlier, but I felt there was a real strong feeling of we have to do something, but what? What can we do to make it more political?
I'm not sure whether we really found an
You,
answer.
okay, okay.
There were several ideas, and
Hmm,
what stood out was that the collaboration and that we should not shy away from
okay,
collaboration across sectors. So this is
great.
all. But specific tractors, I don't recall any specific
Okay.
silver bullet solutions.
This will be one of the key questions that could come back during this webinar and maybe in the other events that EUPHA is holding, because I think it's essential, of course. And um, we thank DJ for your very informative talk, and quite a lot of people already did that in their feedback. And from the organization, we apologize that the only language that we communicate in this webinar is English, and hopefully in the future we are able to facilitate in more innovative ways. So thank you very much for your excellent presentation. And now I would like to move on to our next speaker, who is Catherine Jenkins, who is the Vice President of the EUPHA Health Literacy section, who is one of the co-organizers also of this event. And Catherine is lecturer at the London South Bank University in the United Kingdom. And you will talk about building capacities of non-formal learning providers to promote health literacy across the life course. Catherine, over to you.
Thank you so much. I will just share my screen. So yes, I will be talking about building the capacities of non-formal learning providers. And as Didier has already mentioned, so I'm building on his talk, which is great. So I just wanted to start off briefly with a few definitions. So they're both quite long, but I won't go into them too deeply. I just wanted to show the most current ones. So health literacy. Today, I'm defining it as an asset which works across generations, so very relevant for this particular focus of this webinar, but it's also something that's mediated by different organizational structures and the resources that they've got access to. And it enables people to access, understand, critically appraise, and then actually use information and services for health. I'll also be talking a little bit about the health literacy of organisations, and part of that is health literacy responsiveness. So this is the extent to which an organisation can respond to the health literacy strengths, needs and preferences of the people that the organisation interacts with, including its own staff, to create enabling environments or supportive environments that optimise equitable access to health, not only for individuals, but also for their families and for communities as well. So why non-formal learning providers? So Didier kindly already sort of went through the definitions of formal, informal and non-formal, but I just thought I would touch upon them briefly as well to kind of explain why I chose to focus on one in particular. So the white paper, which I've put a reference to at the bottom there, they talked about locations of learning, and within that they talked about non-formal learning providers. So non-formal learning providers are organised, often community-based organisations that are trusted, where they are providing learning that is not the core business of the setting. So unlike formal learning providers like schools, where education is their main mission, their core business, non-formal learning providers are usually doing something else, and then they also do learning as well, but it's not their main thing. And then on the other side, informal settings, they are more spontaneous, unstructured learning that is part of everyday life. But I think that there is great potential in the non-formal learning providers. And I've just got two quotes here, which come from the Locations of Learning paper. One is from a community-based setting, and one is from a prison. And I think that we can see in those quotes the power of non-formal learning providers that enable people to access education and learning about health that they wouldn't ordinarily think of as being part of that setting where they find themselves. So the first example is just a community centre And the learning that happens there is very organic, but it is also organized, and it's something that is being offered as a benefit through that organization. And the learning that happens in prisons also, education is not the prison's main focus, but it is a very important part of what they do, and it is accessible to prisoners during incarceration. So that's just two examples. I really also wanted now to map settings where health literacy and health learning can happen across the life course. I really like this particular diagram, which takes us from cradle to grave, but I also really like the one that Didier just showed, because it also went further, you know, from preconception and fetal life right through to end-of-life care as well. And again, I think there are other settings that you could also map onto here in addition. Some already mentioned today, so faith-based settings such as churches or mosques, prisons, and then also social media as well. And I've just popped a few more links there to different papers which have different diagrams where they map settings onto the life course, because I think it's really useful and generative to think about the different ways that we can conceptualize this. But I do particularly like this diagram. So this is the main focus of the presentation. It was a bit, how do I say, like a little bit of preamble, but this is really what I would like to tell you about today. So this is a model showing different settings working together, and many of the settings in the middle of that model are non-formal learning providers, and they are all working together as a supersetting approach. Now, if we look at the middle of this model, yes, we've got some formal learning providers. We have kindergarten, we have school, but then we also have these non-formal settings. We have the public library, the museum, the sports club, the supermarket. And what this model is showing, it was developed in Scandinavia. It is showing what they called a supersetting approach, because in public health, there's already this concept of a setting approach, which is using the assets of settings to promote health. But this is like a settings approach 2.0, so it's like turbocharged. And it's more than just a multi-setting approach. It's actually multiple settings working together in ways that produce something bigger than the sum of their parts. So they are part of a coordinated effort. And it can't be implemented top down by councils or by city planners or by academics. It really has to come from the ground up, from the local stakeholders working in those settings. So from public library staff members, from youth workers working in the sports club. And it is underpinned by 5 principles there on the edge. So integration, participation, empowerment, context, and knowledge. And then it's also open-ended. So it can work with other partners. And these partners might not be non-formal learning providers, and they might not be involved in health at all. But they will very much be working closely with the supersetting to make it stronger. And they include things like the public sector, the media, and civil society. And I know that this can all sound quite abstract, so I also wanted to include an example of this in the real world, in practice. And such an example is Tingbjerg Changing Diabetes. So this is a project that operated as part of the city's Changing Diabetes project, which is now Cities for Better Health, and they went into the neighborhood of Tingbjerg, which is quite a deprived neighborhood, and they organized lots of different settings working together to improve community health. So if you're interested in how a supersetting approach looks in practice, then I would really recommend looking up the Tingbjerg work. It's super interesting and very inspiring for how we could involve settings working together rather than working in silos separate from each other. And then I just wanted to zoom in on one of the settings that was in the center of the supersetting model, the library, the public library in particular. So there's already been a recognition internationally that public libraries have great potential and do already do a lot of work to promote community health. They are open access. They are very accessible to old and young. You can get a library card as soon as you're born in some places. And it's also a place where you don't have to spend money to spend time there. And you can also access lots of reliable, good quality health information there too. So they have great potential for health education and health literacy. This is a model of a public library. It's actually quite old. It's from 2012, but I like it because it shows the different overlapping spaces. So the public library not just is somewhere where you go to do one thing, but it's where you go to do lots of things, including health. And then building on this, a more recent model has suggested 5 principles for a health literate, multi-purpose public library. And these, when I say them, you're going to think they sound exactly like the supersetting principles because they're very similar, which I like. It's this, building on previous learning and synergy. So the 5 principles are empowerment, equity, inclusivity, collaboration, and integration. And if we just look back at these principles as part of the supersetting approach, there's a lot of similarities there. And I think the public library is, again, a nice example of that supersetting approach in practice, because the public library is a non-formal learning provider and as a health literacy responsive organisation works a lot with other organisations. It doesn't do this work by itself. It works with formal learning providers such as schools. So school children will often have visits to their local public library, but it'll also work with social workers, community organisations, youth clubs. So there's already lots of work going on in the library that we can take forward, I think, in other settings. There's also lots of work going on in sports clubs that we can learn from as well. So that brings me to the end. I just want to say thank you, and a little bit of recommended reading is the IUHPE, International Union for Health Promotion and Education Global Working Group on Health Literacy, has published just last year a position statement on health literacy, a practical vision for a health literate world. And I really like the fact that they've highlighted it's practical and not too academic. So thank you very much for listening.
Thank you very much, Catherine, for your great and inspiring talk and branding public libraries as super settings. I think it would be great if every library would have that as our logo, although people would still know to understand what a super setting is. But I like you to also frame it as turbocharged in your talk earlier on. And I have a question. Are there any practical examples of settings working together on health literacy?
Yes, thank you. So there is a great example on lead poisoning. So educating children and young people about the dangers of lead poisoning, which is is more important in some countries than others. But I think the example is great. So what they did was they had a public library that was teaching visiting school children about how to spot lead poisoning in things like paint and things like that in the home. They would then take that information back to their parents, their families, so that the information would spread. But it wasn't the public library working on its own on this curriculum. It was also working with an art museum library, which brought in paint samples to test for lead poisoning, and it was working with a local pharmacy, a chemist's, to also talk about the symptoms and the risks. So it was working together with other organisation settings and not just on its own. So I think that's a nice example.
Sure, thank you very much. And checking with Sylvia, are there any questions from you, audience here?
Not at the moment.
Not
no.
at the moment. And there was a comment from someone about that bringing tractors when it's dark is not as effective as when everyone is looking. So re-emphasizing that it's the people that can be the voice, and the voice should be heard. And I think what you said, Catherine, about health literacy is a very interesting contribution. So thank you. Thank you very much, Catherine. And I would like now to move to our next speaker. Happy to introduce to you our esteemed colleague from WHO, Young-jae Yeon, who is Vice President of the EUPHA Health Aging setting. So there's another section, which is another section involved in this organizing of this week. And Young-jae, you are also technical officer at the WHO Regional Office for Europe in Copenhagen and leading the Aging and Health Program. And you will speak about achieving healthy longevity for all in age-friendly environments. So the floor is yours.
Thank you so much, host, and good morning, good afternoon, and good evening, dear friends and colleagues. It's so nice to be here, and on behalf of our Regional Director, Dr. Hans Kluger from WHO Europe, we're so pleased to have this opportunity to participate in this very important webinar on health through the life course and really breaking down silos. And I think what Evita mentioned earlier, the great words of Aristotle, the whole is greater than the sum of its parts. And it's so important that we're coming together, thinking about this topic, breaking down silos, and really achieving this sustainable development goal of leaving no one behind. And so I'm very pleased to speak about our work on healthy aging, because living longer is a great thing, and this is all of our goal. But in addition to that, we want to live long and healthy lives. So let me please share my screen, and you should be able to see it now. Yes, great.
Yes, fine.
Thank you so much. So my QR code is there. Feel free to be in touch with me. So I think we all know that our population is aging rapidly, and we will continue to see a population aging, particularly with the oldest populations of the 80 plus. But of course, within the WHO European region, which consists of 53 member states, we have one of the highest share of older persons in the world. And we also stand at a historic brink and historic shift that this year we have more older persons than younger persons living in Europe. And so there is no doubt that we are living longer than ever before. And this really is the testament of our public health system. And longer life brings with it many, many opportunities for all of us because we are aging. And it also brings opportunities for our families and societies. But the extent to which we can use these opportunities and contribute to our communities really depend on a very important factor, and that is health. And so we've been very successful in extending life, but these extra years are not necessarily spent in good health. And so this graph may look slightly complicated, but the message is very, very clear. You see that this is the graph of life expectancy and healthy life expectancy at birth and at age 60. And looking at the 20-year sort of a trend, we're seeing that life expectancy have increased. But at the same time, there's also increase in the number of years spent in ill health, and this gap is widening at age 60. And we also see this gender gap as well. So this trend is clearly the opposite of what we would like to see. And that is why promoting healthy aging is so important to reverse this trend. So the UN Decade of Healthy Aging is an opportunity for all of us as government, civil society, UN agencies, academias, media, public sectors, and private sectors to reverse this trend. And so we have developed a number of resources. So please feel free to scan the QR code, and we will make our presentations available to have access to all the materials in multiple languages. So one of the action areas of the Decade of Healthy Aging is creating age-friendly environment. And age-friendly environment is context-specific. You can create that at the city and community level. You can create that at a subnational or national level, or you can create at a setting specific, like public library, or age-friendly train stations, or age-friendly hospitals. And I'll give some examples. Essentially, it is an ecosystem in which you can bring different sectors and people together. It allows us to age in place. It gives us the opportunity for our personal development throughout our aging process. It allows us to continuously learn and grow and foster independent living and good health. So age-friendly environment is a proven way to create an age-friendly cities and communities. And we work across the different domains, the domains such as outdoor spaces, transportations, housing, social participations, looking at community services, looking at communications, how we bring people together. And it really signified this profound commitment to address the evolving needs of people in our communities. And so there are some examples that I would like to share. And I think earlier, Didier mentions about creating the conditions for collaborations and age-friendly environment. This model of age-friendly environment is a way in which we can bring sectors together by putting people at the center. So one example is the city of Udine, which is one of the age-friendly cities. And they leverage the GIS technologies, using technologies to create precise health map that align public services, including health and social care services, with the needs of older people. And they involve older persons in the decision-making process and ensuring that all of the local investments are aligned with age-friendly practices. And there are many other cities and communities that are also implementing various programs, like as simple as extending traffic light timing. This allows people to go out in the streets and engage in the communities, and to actually also promote physical activities. Because did you know that just 20 minutes of light physical activities a day can reduce 30% of all-cause mortalities? And it really promote intergenerations collaborations and activities as well. I'm also happy to share with you one of these age-friendly cities is the city of Gaia in Poland. It's another example of how they bring communities together. And they are one of the first cities in Poland to be part of the UNESCO World Network of Learning Cities. And it is the ecosystem of an age-friendly environment that bring people together. For example, the seniors activity centers, the public libraries that dedicated services to, of course, all people, but also older persons, creating virtual platforms, online classes, in addition to the in-person classes. Older persons learn to be connected, to be engaged, to be empowered to pursue lifelong learning. And this is done even during the COVID pandemic, when this is all done virtually. Another example at a national level is Age-Friendly Ireland, where they're very much focusing on the housing part of the age-friendly environment, where they promote independent living to enable people to live as long as possible in their own communities. And the research and evaluations have shown that it actually shows that it delays people from going to nursing homes and long-term care facilities. And what this was pilot tested in 9 local authorities and has since then been implemented nationwide, where it shows that it is cost saving to the older couples of about 90,000 per year. And it shows that this initiative not only reduced the healthcare costs, but it enhanced the quality of life of older persons. So I'm going to start in a couple of slides about our age-friendly cities and communities, our global network, which span across 52 countries in more than 1,600 cities around the world. And of course, we have our national network, our subnational networks that we can engage with them. And this covers about 320 million people worldwide. And so a lot is happening across cities and communities. And you can scan the QR code, you can go to our database, and you can search what kind of activities they've done in terms of learning, in terms of health promotions, in terms of addressing social isolations and loneliness. And you have a lot of examples and contact information from what cities are doing. And so I welcome you to join the WHO family of age-friendly cities and communities with all of our resources. And this really is the ecosystem in which we can implement health promotions, preventions, and health literacy. So thank you so much for your attention.
Thank you very much, Jongye, for your inspiring talk. And you actually already made clear how we personally can join the WHO network of age-friendly cities and communities with the QR code that you showed. It's great, the use of this modern technology in your presentation. That's great. And you talked about the intersectoral work, of course, but also the intergenerational work. And could you give one example of this intergenerational aspect in maybe one of the examples that you have or maybe come to mind?
Yes, of course. One of the example is came from Sweden, Gothenburg, and they came together and think about what they could do to promote cohesion within the community. So they brought different people together, and they realized that they should implement this activity called chatty benches, and they put them strategically in different areas to promote the spontaneous connections and meeting between people of all ages. And it was so successful that it has evolved over time that the cities actually start to recognize that people are coming together, and they organize a program called Dare to Speak around those chatty benches to talk about mental health issues and to bring the various services from the communities to the people. And so this is a great example of how within this environment, you bring the health and social sectors together, you bring the urban planners together, and it actually shows that people are coming together. And so now they are actually exploring other ways to enhance these benches by actually thinking of incorporating solar panels so that older persons, younger persons can charge the phone to play music, to think about heating the benches because it's very cold in Sweden. And it really demonstrates this ongoing collaborations and how to improve and how to bring different people together. So I think that's a really good example of intergenerations, because when you create an age-friendly environment, you are creating age-friendly for all ages.
Yeah, interesting. Thank you very much. And actually, there's a comment from the audience that so Sebastian Levescu says, although I agree with this concept, I wonder how this type of project in the future will be justified as the amount of taxpayers decreases and the number of retired non-taxpayers increases. All this without exploiting young immigrants who themselves are often from low and middle income countries. What's your take on that?
Thank you. That's a really great question.
Yeah.
As I work in the area of healthy aging, I'm always confronted with a lot of challenges with exactly this topic. You know, if we invest in older persons, are we actually taking away the investment or support for the younger generations?
Mm-hmm.
And this is a misconception. So I think we need to start thinking of breaking down the silos that actually, if we invest in age-friendly environment, if we invest in the life course, we are creating a win-win situations that benefit everybody. And I think we have lots and lots of examples that perhaps later on we can share that actually we need to change this narrative. It's about creating an environment for all of us. And as what Didier mentioned earlier, it's really creating this conditions for collaborations. And I think Catherine mentioned earlier that, you know, if we put people at the center, and it comes from the ground up, we know what the solution is. We can gather the resources and we can address them and we can benefit everybody.
Yeah, and that's actually one of the things that was said at the high-level panel on Monday for the kickoff of the European Public Health Week, that €1 invested in prevention gives 14 euros of profit in the end. So economics and economic talk is a very important driver, I think, for having our voice heard also in Brussels.
If I can share another example, since you mentioned about the economics case, we've been also looking at the life course perspective in promoting physical activities, sports and recreations. And what we found was that we looked at the social return of investment. For every €1 spent, or not spent, €1 invested, you get €3 in returns. And that translates to we looked at examples of Wales and Wallonia, Brussels. So using Wales as an example, if we invest 1.2 billion, we actually get back about 3.4 in social returns on health and social connections and social capitals. And so it actually translates to benefit of everybody. population is healthier, then we can contribute more to our communities and our economy and our well-being economy.
Thanks for this very clear and strong statement, Young-Jae, at the end. And we'll continue our webinar, and we'll come back. We'll have a panel with all the panelists where we will have some kind of interaction with each of them. And now I'm happy to introduce our next speaker, Eric Breton, who is president of the EUPHA Health Promotion Section and professor at the EHAS, the French School of Public Health in Rennes. And Eric, you will speak about the role of community health workers in building bridges and improving community health literacy. The floor is yours.
With the mic on is always better. Thank you so much. I'm very pleased to be here today. And I'd like to thank, of course, the UNESCO chair for inviting me and for also the EUPHA. So I'm sharing my screen. You should be seeing it now. If I'm not wrong, let me know if there's
fine. It's no problem. Great.
Okay, very well. So I'd like also to thank my colleagues who actually contributed to the studies we conducted on local health contracts. That will be the topic I'll address today. And so basically the life course perspective, as you know, is a very hard nut to crack. It can have many meanings, but in public health perspective, it often entails the idea of not restricting our focus to a single age group. In fact, when we take a step back from our focus on specific age groups or population subgroups, what basically unite us as children or parents, grandparents, neighbor, whoever, is more or less a shared experience of daily living conditions. So in other words, when we think of it, so children, and for instance, children cannot live happy lives, happy and fulfilling lives if their parents are struggling on a daily basis with issues such as poor housings, low wages, precarious employment status, and discrimination. And so, sorry, I'm trying to, improving daily living conditions is therefore an important entry door for life course perspective. It is also a central leverage point to reduce inequities in health. This is one of the core messages of the 2008 WHO Commission on the Social Determinants of Health. So the commissioner's message was very clear. And I mean, 2008 is a bit far back, but the message is still crucially important. So there will be no significant reduction in inequity in health within and between countries without improvement in daily living conditions. So this brings us to consider what exactly makes these daily living conditions bad for our health and central drivers of inequalities. So we know from decades of research on health inequalities that living conditions are associated with level of resources, opportunities, and different resources, exposures to environmental risk factors. So poor living conditions, such as the ones related to housing or employment, are also a source of stress and shames that wear us out. This is basically new perspective on inequalities. So this is where the issue of breaking silos come into play. Improving daily living conditions cannot be achieved through the action of a single sector of society. So improving housing or work conditions or providing secure environment for our children and adolescents are actually extremely complex enterprises. So breaking silos calls for joinous governance, and it's something that has been repeatedly and continuously called for in public health literature, but it's still something that many wonder how to do, how we can do it, basically. So I want to share with you the experience of France in developing at the local level some kind of health and all policies instruments. And that example is showing some benefits. So in France, the Health Act of 2009 introduced the possibility for regional health agencies to sign agreements with local governments that set a number of objectives to improve population health and equity. So the agreements are known as local health contracts, and they cover actions in the field of prevention, health promotion, environmental health, and access to healthcare. So what is very interesting with this new legislation is that it did not say anything more than local government could engage in actions in those areas. So it means that it has left local governments much leeway to engage in actions that closely fit with their circumstances. So they were able to adapt the policy to their context. So at the core of the local health contracts, there are community health workers that are managing all the activities. So their missions are extremely broad, I would say, as they cover population needs assessment. They mobilize local partners, they define the actions, they support their partners for their implementation, and they also conduct evaluations. So that's quite I'd say a job, a workload. So as we can see here from our national survey of local health contracts, basically those contracts, they address a very broad range of public health problems. There's just part of them. We look at environmental health topics. They also address many of those topics. So what do we know about the benefits associated with local health contracts? Basically, we know that they produce new actions on the territory. We know that actually those actions are more better integrated in the context of the local community. We see that basically the elected officials who used to be very much focused on access to healthcare services, because we have many territories where there are some kind of medical desert, we call it. So there's no GPs and a lack of GPs and health professionals. So basically the local health contracts had them to actually broaden up their perspective on health. We saw that in contracts, even though they sign at the start of a contract that may be a 5-year long contract, they sign for a list of actions. What we say is that basically over the duration of the contracts, they develop new initiatives that were not planned. So that shows that basically they can adapt to changing contexts of the territory. They are able to overcome those silos in some ways. And the last one is basically they can actually, I'll use the next slide to explain. We've seen all those topics they address, but actually it's what is not seen, what we saw behind those activities is the fact that we have actions that used to be just on one topic or one problem, that actually when you break down silos, you have partners from different fields that basically collaborate. So as you can see, if you have only nutritionists working on that topic, what we'll get at school are basically education sessions. It's more, they can do much more than that, of course, but typically they will focus on basically education. If you have a nutritionist working with environmentalists, what you'll do is you're opening up a realm of possibilities. And we've seen that, we saw evidence of that in many of the descriptions of the actions that were actually implemented over the country, okay? So now I'd like to conclude my talk basically with the idea of health literacy. So of course I cannot do as well as Catherine Jenkins just did, but I'd like to say that just to build on what she presented, that was very interesting, especially the library stuff. So just to build on what she said, and to say that health literacy can also be an instrument to improve intersectoral action. So we do agree on that. So we need to basically recognize that unequal distribution of power is a key issue when a local community tries to improve its daily living conditions. Agriculture, so farmers do have some leverage with their tractors, as Charlotte Marchandise mentioned early on from the presentation. So if you take, for instance, regional housing policies, so you see that authorities and elected officials, they will often tell you that they're doing their best to improve housing, but cannot do more, even though people are struggling to find proper housing. So yet at the same time, you see the same people that may actually invest a lot of resources on other projects that are far less impactful on people's life. So we need to recognize the importance for local population to not only be health literate about the determinants of their own health, and to know that what is a proper diet, what is, how to access healthcare services, all those determinants. We need also communities to be health literate. And those communities to be health literate means that they can actually engage in the policy process and implement advocacy strategies that may help them actually have their voices heard and their needs accounted for. So they need to be able, basically, to occupy policy spaces where they are not seen as entitled to be or to belong. And this is a clear characteristic of power relationship. I mean, we have basically vulnerable groups that will never be invited to actually provide, to have their voices heard. So to conclude, basically, so community health workers, when enabled to do so, they can be really instrumental, not only in breaking silos, but also in contributing to improve the community health literacy. And this will enable people to address some of the upstream determinants of their health. Thank you very much for listening.
Thank you, Eric, for your great talk, very inspiring. And we have a question. First one is more a question about what kind of difficulties or did you face in with making these health contracts in your example that you gave with France? I mean, what kind of issues?
Yeah,
because you said there were a lot of them, but
no, it's an excellent question. The thing is, when you one of the characteristics of the local health contracts at the time being is the fact that they actually, you need to go back to the French context. And the French context is one with a health system that is extremely centralized at the national level. So it's not something natural for local authorities to be involved in issues regarding health promotion or prevention. They're involved, of course, in sanitation, in collecting garbages and things like that. But when you get to other environmental health, for instance, issues and prevention of promotion, they're not this is not something they're used to. So this is a context, and the reality for local health contracts is that it's quite a vulnerable instrument because you have basically the funding is on a short-term basis. So it can be 3, now it's more like 5 years funding. So it means for the community health workers do not have much of a horizon on where they're actually going to be beyond that. And so and their profession, I mean, their role is not so well recognized. I mean, we're trying now we're working actually we're conducting a study to better understand what is this trade to be a community health worker? What does it involve? What kind of competencies are needed to? And what we found is we're finding we're not done, but what we can see, it's extremely complex job. I mean, it's you need to talk different languages. You need to be able to talk to people of the transport system and to people of the health system and the people of the leisure system. And you need to have their languages. And at the same time, you need to create some kind of language that people can talk to each other. So basically to conclude on that question, it's that we have an instrument, so the local health contract, that is still quite fragile. I mean, in terms of job perspective for the community health workers. The funding is very restricted. So, I mean, it's an instrument that has, if there's something happens in the community, like COVID, if COVID happens, they don't have necessarily much leeway in terms of resources to address this kind of problems, because all the funding is for different specific topics.
Yeah.
And we found, and I'm concluding on that, and we found that basically during the COVID pandemic, basically when the people were stuck at home, not having to take care of their kids, everything was falling apart. I mean, there was the function of the community health worker is so central. So if that person cannot fulfill its mandate, everything falls apart. I'm done.
Thank you. And thank you for amplifying the voice of community health work and how intersectoral they are already working, and what a great work they do. We are now into the next book lab question for you, audience. And in the meantime, we're setting up the screen so we can have all our panelists in view. But the question for you is, what would be your first step to break down silos for better health through the life course, which is the key question of this webinar. And while you complete the book lab, we invite our speakers to come. Well, just stay on your seat at least, but you'll be back on the screen. And we asked all of you to, in your preparation for your talk, to give a key message. So maybe it's good to invite DJ and Catherine, Young-Jae, and Eric. A key message for breaking down the silos, and we have detractors in mind. Maybe you are inspired to give some kind of reflection after you heard everyone's contributions. You heard the contributions from our audience. So I'll do it in the same order as the speakers. So DJ, would you like to go?
Yeah, thank you very much. I just would like to come back to the detractors and the political issues. We talked about the cost effectiveness and the return on investment of what has been done. And of course, as Eric just said, when there's multiple factors, it's extremely difficult to move to conclusions in the field of the economic health analysis of what is done when you break down the silos. But what is great now is that we have many new framework, and especially one that is called the social return on investment, that counts the price of all the dimension. For example, loneliness of old people has a huge cost from a social point of view. And when you count the return on investment, you have to take that into account. And I just would like to share you a few slides. The first one is about young people. When you work at the community level in a health promoting school and community approach. You can demonstrate easily that multi-component intervention based on partnership between the social sector, the health sector, and the education sector has a return on investment much higher than the interventions that are done only by one sector. This is also true at the other end of the life. When you generate interventions at a local level, having together the social sector, the health sector, and the community workers, you have a very high return in investment, and especially the case when it's about home care and help. And I really like, the incredible work of Jonathan Silas and our colleagues from the Center for the Economics, at OECD and WHO. Clearly they show that this intersectoral policies that aim to promote the health of old people, for example, are key component of the sustainability of our social security system. So this is clearly one of our tractor. One of our tractor is the cost effectiveness of what we are doing from an intersectoral point of view that would help the different states and the EU to guarantee the sustainability of our welfare states.
Yeah.
Over to you, Rolf.
Thanks very much also for your additional slides, although we didn't talk about that, but it's really strengthened your case and the tractor that you suggest. Catherine, what was your key message or takeaway or, learning?
So, especially after hearing everybody speak, I think my key takeaway is continued collaboration across silos, and I'm specifically thinking of within EUPHW. So we have different sections within EUPHW that focus on different areas of public health. And I would just say that in the EUPHW Health Literacy section, we are very open to collaborating with other sections. And I think that's something that we should really prioritize and continue doing so that we don't end up with such siloed thinking or any duplicated effort, but we're very open to working together so that we can take a sort of a mini supersetting approach in the way we work, I guess.
Great. Yes, thank you. Okay, good. Young Ye.
Yes, great. It's such a great discussions and comments from our audience and participants. I think I learned a lot from our panelists, and I have 3 key messages I've learned from them. Of course, Didier mentioned how can we create the right conditions for collaborations, and what Catherine, you mentioned from the ground up, because at the city local level, we know what we need to do, and it's about bringing the right people together. And what Eric says about the voices of the people must be heard, and their needs to be accounted for. And I think when we talk about cities and communities, it is where we live, work, and play. And so this is a important areas for collaborations, and the Age-Friendly Cities and Communities Network essentially is the ecosystem in which we can actually speak the language to bring people together. And so our principle is nothing about us without us. And I think this was something that I think someone also echoed before, that if we come together, we can bring the solutions about how we can create change. One example, that I can give was, this was during the pandemic in Northern Ireland, which in a very impoverished neighborhood where older persons are, in the lockdown. They're not allowed to go out because of the restrictions. And what the community did was that they know all of the older persons, so they actually create a care package they call Hug in a Box, and to provide all these informations on health and literacies, and so that they can digitally connect with people. And the cost, as what Didier mentioned about, it actually doesn't cost anything because it's all run by volunteers because they already have this network, the ecosystem to bring people together. And they were able to respond very quickly, even in emergency situations. And there's lots and lots of example around the world, and not just in high income countries. As you know, I think one of the comments from Sebastian, age-friendly cities exist in every communities all around the world. If we bring people together, we put people at the center, the solutions, the innovations will come. And that's why I think we need to also build the case for this common language, the system, the mechanism to bring people together.
So rather a people's movement than a tractor.
Yes.
Thank you very much, Young-Jae. And Eric, what would you?
I mean, my message would be that public health must be disruptive. We must be disruptive. And so silos are basically the routine of our administration, of our bureaucracy. It's normal. We all have our routine, and the silos are basically the expression of those routines. So our tractors, I would say, are people who got engaged. And those are our tractors. So the people, when they get engaged, they actually can move things quite fast. We've seen it happening many times over. That's how revolutions takes place, basically. And so, and for this, we need community health workers. I mean, if we think of the local level, so community health workers that are able to create new participatory spaces. If you don't create those participatory spaces, you don't engage people. People don't know each other. They don't connect. You don't build actually their capacities to disrupt basically the routine of our system. That's what I would say.
Right. Thank you very much. You say it all. Public health must be disruptive. Maybe it's good also to have you, Iveta, to give your take on this.
Thank you very much. Yeah, I cannot agree more with with my colleagues, because I think you said it all what I had in my mind, like what are the possibilities of breaking down silos. And despite the fact that, of course, the economics has a strong and powerful voice, I would say that also collaboration, communication is also very important, and especially collaboration, cross-disciplinary, cross-sectoral collaboration, as was said, because I really believe in innovation. And I really believe that if we collaborate across sectors, across disciplines, we can bring the innovation, we can touch upon the untapped potentials, resources. And I would say, like Sandra Galina also mentioned on Monday, that we have to find, like a public health community, also to find ways how to collaborate with the private sector. And so far, we've been a bit kind of like, we did not want to get our hands dirty, but I'm very happy that, for example, in the WHO, I see already this turn that, there is this there are private actors where there is a lot of development in AI, in genomics, in precision medicine, even in social innovation. And the development will go on even without us. So I think we just really have to be clever how to collaborate also with these sectors to capitalize on innovation and to create the innovation ecosystems. And I think we really have to find ways how to do that cleverly.
Thank you. And I also want to check with Sylvia what our participants to this webinar have answered to the question. Oh, look at that. Well, to empower people and healthcare organization by means of health literacy, identify silos, establish common goals, promote cross-sector work, a lot more. A joint incentive, listening. I think that would be also good to do that. Apart from being, or as part of being disruptive, listening is where you start. And shared agenda, inhabitants' participation, and cross-professional working. I just pick out a few, and we'll all include these great comments in our web page, because we will make a web page with all the presentations you heard today, the video recordings, the PowerPoints, a summary of what you as participants have contributed, and all the additional resources that some of our presenters already put in their PowerPoint, but also we will list them for easy access. And I think that with thanking you as participants for this great input, thanking also the speakers for their great and inspiring talks, and wishing you a good rest of the day. And maybe you have time to join one of the other events during Public Health Week. Maybe, Iveta, you can make an advertisement for your Public Health Week for today and tomorrow, and then we'll close the meeting. So, Iveta, I give you the closing word.
Sorry, all the information can be found at the EUPHW website. So there are a lot of activities going on online, but also in person, which is very interesting in several countries. So definitely we would like to invite you for the events today regarding NCDs and all the healthy aging and so on, like what we discussed this morning, and also for tomorrow. Tomorrow is the day of the youth. The EUPHW Next is in charge for tomorrow's event. So please enjoy still the European Public Health Week, and thank you very much for joining today.
Okay, thank you everyone, and we hereby close the webinar.